guys introduced ourselves, come into the room, we would, I've already said it like 2 or 3 times, but we would introduce our name, tell who we're affiliated with, and ask for consent to see the patient, get the patient's name, date of birth, wash your hands while we're talking. So I understand you're here today for a musculoskeletal exam, is that right?
That's right.
You'd say yes, and then proceed, finish washing your hands, so forth and so on. And so we're ready to start the exam, so we can go ahead and have him, if he's comfortable, disrobe his shirt and go ahead and take off his socks and shoes, so that'll be done so I can move through the exam in a timely manner without having to really slow down. All right, go ahead.
Okay, so cervical spine inspects and palpates the C-spine, paracervical, and trapezius muscles bilaterally.
Yeah. So basically, you want to start here, and if you want to, what a lot of students will do is they'll go ahead and they'll palpate the whole spine at one time to kind of have that done. And so, because when it continues on, it probably says palpates thoracic, inspects thoracic, so forth and so on.
Yeah, once you go into the thoracic.
Yeah. And so if you guys want to, you can do it, but I'm going to do it as is on the checklist here. So she said palpate the cervical spine, and so just kind of walking that down, making sure that I don't see any type of deformities on the C-spine. And then what you can do is kind of go side to side. And what I usually try to do is just kind of push over the paravertebral muscles just to make sure I don't feel like any type of spasm. And then, of course, his trapezius muscles are going to extend out a little bit further. And so just palpating over those areas to make sure he's not tender over those particular areas. Okay? His traps come down. All right, next.
Forward flexion and extension.
And so here you can say, okay, we're going to have you do a few movements with your neck. And so touch your chin to your chest if you can. Okay, look up at the ceiling. All right, come back to neutral. Look at me. With keeping your shoulders straight, look as far as you can right. Look as far as you can left. All right, come back to me. Keep your shoulders in a regular plane. And then touch left, touch right. Okay, now see, he's even trying to move, so it's easy to do. It's easy to do if you're not careful because you want to be able to touch. The goal is not to touch the ear to the shoulder. The goal is to see if he has 40 degrees range of motion, okay?
So that was all the rotation and lateral bending. And then on the thoracic and lumbar spine, there's also the flexion and extension with hips stabilized.
Okay, but they want me to inspect, I would assume, and palpate on there first, right?
Yes, yeah.
So, now what I'm going to do is kind of pick up where I was left off and kind of come down his thoracic spine. Here again, just making sure I hit every spinous process. Get a small fee for this little massage here.
Need more pressure.
Would you like oil too? So then I'm going to go down kind of by the paravertebral muscles and just kind of palpating there to make sure I don't feel any kind of muscle spasm. And just making sure there's no tenderness. Okay. And so if you want to, you can, while you're here, because nothing to say that you've done a thorax and lung exam on this patient and really check this, because this patient's here for a different way. So I always kind of check just the lateral muscles of the back just to make sure I don't feel any abnormalities there. Okay. So I've done that. So now I want to do forward flexion with him. Do you mind sitting on the floor? Is that a problem? So now don't fall over with me. Now what I want you guys to do from a clinical standpoint, step out, is I want you to kind of help this person by holding and adjusting their hips. So as far as you can comfortably, I want you to forward flex. If you can touch your hands to the ground, that's fine. All right, back up. Okay, a little gymnast. And now if you can extend backward to the wall. Okay, good. Well, that's far. I don't want to have a walk. Just extend back slowly. All right, that's good. That's fine. All right. Now the next thing we'll do is lateral bend. So keep your arms by your side. Do not go forward at all. I want you to just kind of tip over and try to touch the side of your knee. Good. Other side. Good. Back up. Now the last thing we'll do, this is going to be really hard, is I want you to rotate your torso. You're not going to be able to go very far. So just turn a little bit and I'm going to stabilize your hips, okay? Good. Other side. Good. So you notice there, he can't move much and he's pretty flexible. And so step back up here, please. And so there's not a lot of movement with the torso if you truly do it right. Don't allow those hips to be engaged and go forward, okay?
Okay, moving on to the shoulder bilaterally, inspects shoulder anteriorly and posteriorly.
So remember, there's two areas there. So he does look, well, I'm not supposed to say anything negative.
No, I do.
Symmetrical.
Yeah,
But
they
you look for
Yep, just my
symmetrical.
tires.
Yeah. All right, so look for symmetry. If he tells you it's okay, I can't tell you.
The mouse arm at the computer desk.
So, and then look at the back, okay, making sure it's symmetrical, all right? All right, so after I've inspected, what else you want me to do?
Locates and palpates the greater tubercle, bicipital groove, clavicle, SC and AC joint.
Okay, he's pretty muscular, so. Okay, and then come up from there and find his greater tuberosity. He's got a lot of muscle meat over his, he really does. It's a little bit harder to find. But sometimes you can track your hand in here and have them rotate like that, and you can kind of feel where that groove is. He can kind of feel me kind of in that little sulcus right there if I push hard, but it's not comfortable if I push hard. For purpose of this exam, you guys are gonna be able to do just one side, and I'll let your proctors know that. If you can do one side right, you can do the other side right. So when inspecting, I want bilateral, but when palpating and doing movements that can't be done bilateral, you can just palpate that one side. Does that, everybody hear me on that? So just make sure with like palpation. So I would do the same thing over here. So you wanted me to do the deltoid, the bicipital groove. This obviously is his clavicle coming over, which is gonna meet and make his AC joint right there. If I want to go in right here, that's his coracoid, but it feels a little weird. Okay, but you can feel it. It's prominent right there, a little bony prominence. Was that everything?
And the SC joint.
Say it again.
The SC joint.
Sternoclavicular.
Yeah, that's the one we just did right here.
Okay.
Yeah, sorry. But yeah, you can kind of feel. And over a joint, guys, you'll feel an indentation just a little bit where it meets, because that's where the actual joint is. It won't be consistent like the bone.
Flexion and extension.
All right, so for this, we should be able to, for the most part, do it with him sitting down. If you guys want to, you can stand him up. But we'll do that just to give a better picture for you guys. So we'll see you go all the way up to the ceiling, and then back as far as you can go comfortably. Okay, that's good. Extension.
Abduction and adduction.
So hands by your side. You want to go up, keep pump, good, and back down. And then give yourself kind of a hug across, okay?
Internal and external rotation.
So there's a couple ways you could do this, but the most common would be here. Make your elbows touch your side and stay there. So what you guys can do is actually get behind the patient to help them with this, but you gotta be able to keep it to where you can see. All right, go all the way out as far as you can, and then go all the way in as far as you can. Cross over if you have to, yeah. So you remember, you can internally rotate much further than you can externally rotate, okay?
Okay, elbows. Inspects humeral shaft and elbow joint line bilaterally.
So basically here, looking at the kind of the olecranon process at the very bottom, and then his lateral epicondyle and his medial epicondyle, the really bony prominences here. The humeral shaft is going to come down, and like I said, he's pretty muscular, but I can kind of palpate back there where his bone is. All right, what else?
Inspects, locates, and palpates medial and lateral epicondyles.
Okay.
Inspects, locates, and palpates the olecranon process.
Mm-hmm.
And
All right.
then flexion and extension of the elbow.
So both arms here, just follow me, up, out. Keep your hands at your side. This is where we're going to do supination, pronation. Okay, as long as he keeps his elbow there, that's fine.
And then wrist, hand, and fingers bilaterally. So inspects and palpates wrists, hands, and fingers.
So turn both sides over. Look at the anterior side or dorsal side, posterior side, and then look at the volar side, okay? And so there, you want to kind of palpate this wrist joint where the radius and ulnus meet. And then remember, you got all your carpals in here, and so just palpating over where those are. Now, what you can also do is palpate on the palm side, make sure there's no tenderness. And then we can kind of walk out the metacarpals from a top and bottom approach. I'm hitting from top and bottom with both of my fingers. And then once you get to the fingers, you can do this kind of quickly, but like this, and just do every finger side to side, and then do your top to make sure there's no tenderness. Now remember, when I'm doing this, after I inspected, I've already looked for the redness, the ecchymosis, bruising, swelling, whatever the case may be. But you want to do that. And like I said, I'm okay with you guys doing this on one hand only to make sure it's okay. But the biggest thing that students forget to do is they forget to look at this palmar side. They'll get so concentrated on this dorsal sphaxostick of the hand that they forget to give any attention to the palmar side. So don't forget to do that.
Assesses wrist, flexion, extension, radial deviation, and ulnar deviation.
Okay, so up, ride your motorcycle, flex down, okay? And then I want you to keep your elbows by your side, hands out, go out as far as you can, go in as far as you can. Okay, good.
Okay, assesses finger, flexion, extension, abduction, abduction.
So here, open, together, back out. Do both, there you go. Back together, make the number 4. Bring the thumb out. Thumb together, thumb pointing forward, back. Okay, opposition. Good.
Hip.
All right.
Inspects the hip joint bilaterally.
So here, basically, you want to turn the patient and get down to, I like getting eye level so I can kind of feel where his bony prominences are, try to figure out where his landmarks are. And here again, just looking to see if he's symmetrical or not. So greater trochanter, okay. ASIS, PIS, looking across, making sure your hands kind of line up in a natural position all the way across when you're actually inspecting. We're not going to inspect some of the more modest areas, okay?
So that was inspect, palpate, flexion.
Okay. And so on this, there's a couple ways you can do it. You can have him hold the bed if you want to. If it's an elderly patient that you don't feel comfortable with standing, you think it's a high falls risk, then lay him down to do this stuff. Harrison, I think he's still a little bit in his prime, a little bit. So I think he can lift and do this. So hold the bed for support. Lift your hip up. Take your hip all the way back. Okay, don't let yourself hit the table there because that would hurt. I want you to, and then adduct across. Okay, good. All right. And the internal rotation, if you feel comfortable with your patient, here again, he's young. I feel like he can do this. So you can kind of make the number 4, okay, and then do the opposite number 4. Okay, good. Okay, so he's doing internal, external rotation. Otherwise, you can lay him down. I say he's older. I say it's 5 years from now. Now what you can do is say, okay, I want you to flex your hip up. Okay. Now the only way we could do extension is we'd roll him over, put him in prone, and then have him just go back as far as he could. Okay. That's how we do extensions. Make the number 4 with this leg. Okay. Put it back. All right. Flex the leg in, up. Yep, like that, and over. Okay. Back out. You can do adduction here, go out with your leg, cross your leg over, right there. Okay, so if somebody geriatric, you can do that, but it'd be a much less fall risk. Okay?
Okay, knee, inspects knee bilaterally.
So you can do this with him here or with him standing. I like doing it in this particular position. So you can see good quad muscle definition here as the patella tendon comes over and attaches. You can look at the actual knee itself. You can actually bring this out if you want to. Relax your legs. And as you say, you know, the knees here, they're going to move. The patella's going to move back and forth a little bit. Make sure it's not blottable. You want to find his actual joint line. His joint line is right there. And as you can see, it's on the inferior aspect. It's not up here where I thought it was back in the day before I got into medicine. But his joint line, you can walk it all the way around. Okay, and make sure there's no tenderness there. Palpating over the area, prepatellar bursa, where a couple of those other bursa would be along the side. His tibial plateau is right here. If you're looking for lateral and medial epicondyle of his tibia, they're right here and right here, okay? And he's got a lot up here where his femur is. It's a little bit harder to find on his femur bone, but right there is his femur areas. And then his joint line obviously is right there, okay? So making sure you hit all those particular areas. And the patella tendon obviously comes over and then attaches. So with this, I'm sure it's gonna have me do knee extension, knee flexion.
Yep.
So knee extension you could actually do here, but flexion you can't. So there's two things you could do. You can stand the patient up, or you can have the patient scoot over to the edge of the table. So knee extension, both legs all the way up, okay? All right, slide over to the edge of the table without falling. Now flex your knee back, so you could do like that. Or you can have the patient stand up and have them flex like they're gonna kick themselves in the bottom, okay? You can tell I'm a dad because I don't say butt, I say bottom.
Okay, ankles, feet, and toes. Inspects ankles and feet, the dorsum and plantar surfaces.
So here again, don't forget the inspection part. Biggest thing here is making sure to look at all the foot. Many times students will forget to look at the back. Also, if you have a toe fetish, get over it. You need to spread the toes out and look at the toes. All right.
Palpates over Achilles tendon, medial and lateral malleolus, dorsum, and plantar aspects of each foot bilaterally.
Yeah. So the Achilles tendon, you can feel it right here. And then go around the malleolus, medial and lateral, over the foot bones here. And then you can walk out the metatarsal each side. And then you can walk every toe all the way out. I'm just making sure, you can see there, I could have him stand up, but he has an arch, okay? Pretty good arch here. You can also, if you want to, palpate along where the plantar fascia is, make sure there's no tenderness there, and just make sure there's no overall tenderness on the bottom of his foot. Okay.
And then ankle is dorsiflexion, plantar flexion, and inversion.
Okay. One of the things you can also do, I like to do on the ankles, I like to kind of rotate it around myself. You don't have to do this per the checklist. And then actually have him do some movements. So can you dorsiflex, plantar flex? Okay. Now I'm going to stabilize your feet right here. Try to invert, evert. Okay, good.
And then toe is flexion and extension.
Flexion, extension. All right. Is that it?
Yep.
Yep. I think on neuro.
Wash your hands.
Wash your hands. You have any questions? I think hey guys, before you leave, one of the things I think that's in neuro, but just going to show you here. Put your feet about this far apart. It's always good to look at a person's stance because you can see how that arch lines up on the floor. You can also look from a posterior position and sometimes see if a patient's more pronated than supinated by the way their stance is. His right now is a little bit, I would say, pronated just a tad. He's not exactly neutral, but you can also assess that. Put your shirt back on if you like. Do you have any questions for me? Any questions from the class?
No. You didn't check my ankle pain. That was my chief complaint.
This is just MSK Exam.